Great. Well, thank you. Good morning. We'll be touching on introducing hypogonadism in the aging male, management of hypogonadism, but really we'll be trying to get into more of the controversy with the cardiac risk associated with it and prostate cancer, and is it safe with testosterone replacement therapy. So late onset hypogonadism, ADAM, etc., is a clinical constellation of age-related decline in serum testosterone, as well as an assortment of multiple potential symptoms and signs. So as you see at the bottom, the more severe ones: loss of hair, osteopenia, weakness, testicular atrophy, libido, fatigue, etc. So the Endocrine Society Clinical Practice Guidelines states for a diagnosis you should have 2 measures of AM total testosterone, and those should be less than approximately 9.8 to 10.4 nanomoles per liter. They say to look at the reference limits for your local lab that's performing it, as some of the assays can be different. If the patient has any reason to have an increase in sex hormone binding globulin, there are extremes of age, hepatitis, liver disease, thyroid disease, if they're on any anticonvulsant therapy, or HIV positive, then you can consider looking at the free testosterone and the sex hormone binding globulin. So if we just take a step back for a second and look at what is total testosterone, what it's made of. So it's composed of about 45% that's bound to the sex hormone binding globulin, 50% that's bound to albumin, and about 2 to 3% that's free testosterone. The other term that comes up pretty frequently is bioavailable testosterone, and this is composed of the free component as well as that bound to albumin. Some people suggest that bioavailable might be a more natural form of testosterone and more clinically relevant. When they actually compare bioavailable and some of the equations used to derive this compared to total testosterone, it doesn't necessarily add a lot of clinical utility, and it's not particularly available and can sometimes be expensive for the labs to run. So that's why we say just starting with total testosterone would be reasonable. So who develops late onset hypogonadism? Well, there's an interesting study that I'm sure most people have heard about called the Baltimore Longitudinal Study on Aging. The goal here was to look at what normal aging looks like in males. The whole initiative was started in 1958, and they've collected 40 to 50 years of data now on what normal aging looks like. So in particular, when they looked at what low testosterone does, they set a lower limit of normal as 11.3. They got this limit by looking at the lowest 2.5 percentile of their cohort in men aged 21 to 45. So that's how they defined 11.3. What they found was that from about age 30 onwards, there's a decline in serum testosterone with age. Each of the lines represents a slope in the decline of serum total testosterone per decade. The top one is total testosterone, and the bottom is free testosterone. The incidence of low serum testosterone increases per decade, and as you can see, it picks up in the 50th to 60th decade and increases from that point forward. There was one other trial that was actually cross-sectional in design rather than longitudinal from Europe. It was multi-center and looked at just over 3,000 patients aged 40 to 79. What they found was that the total testosterone decline was about 0.4% per year. Other reports in the literature quote about 1 to 2% decline per year. What they found was that there's increased comorbidities that were associated with lower testosterone. Higher BMIs were associated with the lower testosterone, and conversely, smoking was actually associated with the higher total testosterone, but also a higher sex hormone binding globulin, so the free testosterone was a little bit lower. So we know that the incidence increases over age, but what's the effects of having this low testosterone over time? There's a really nice prospective study here that was conducted in just under 2,000 men aged 20 to 79. The average follow-up was about 7.2 years, and they defined a low serum testosterone as being less than 8.7 for this study. So looking at the baseline characteristics in the two groups, the low testosterone group actually was low. They had an average testosterone of 7.6 compared to the normal group, which had an average of 16.3. In the low group, they also had increased waist circumference, increased BMI, higher incidence of renal dysfunction, hypertension, diabetes, and metabolic syndrome. Other factors like stroke, MIs, cholesterol, and alcohol use were also comparable between the two groups. So when they analyzed everything and accounted for all the other covariates and looked at the hazard risk of having low testosterone, they found that the all-cause mortality was higher at about 1.92, the risk of cardiovascular disease 2.56, and cancer was 3.46. If you look at the Kaplan-Meier curve over time, people with low serum testosterone have an increase in mortality and decreased survival. This is particularly noticeable in patients that are of older age. So the risk associated with a low testosterone in your later decades of life provides more risk than those that are of younger age. So looking at this, the evidence is convincing that a lot of us are going to end up with late onset hypogonadism as we age. The symptoms certainly can detract from quality of life, and it also may be associated with risk of attaining other comorbidities as well as increasing mortality. So looking at treatment seems like a pretty attractive alternative. When you're looking at any treatments, you first have to define some of the contraindications. So breast cancer, because of the peripheral conversion to estrogen, is a contraindication. Obviously, if you have prostate cancer that's active or there's high concern, then you have to properly evaluate these people. If your hematocrit or hemoglobin is very high, it's been known that testosterone can increase these levels, and you have to be careful in this subgroup. If people are untreated sleep apnea, lower urinary tract symptoms, if there's poorly controlled heart failure, or those people that are looking to be fertile or azoospermic or plan to have children. I was looking into that. I think part of it's might have to do with the metabolic syndrome and the BMI, the weight, etc. And also with testosterone, you have increased potential for edema and water retention, sodium retention. So I think there might be an interplay with that. I'm not sure, to be totally honest, if they looked at it specifically for cause and effect. Yeah. So there are several different options for testosterone replacement. You can do IM injections, you can use a testosterone patch, androgel, buccal testosterone tablets, or you can actually put a tablet in subcutaneously. So if you start patients on testosterone replacement therapy, you should probably see them back in about 3 to 6 months. Take a history, see if they're compliant with it, do they have benefits from it or adverse effects, and you can examine them if they're using a transdermal approach. Are they getting rashes from the topical use? Follow their PSA digital rectal examination if they have risk factors as per what you'd normally be doing in this patient cohort on an individual basis. And check their total testosterone. Are you hitting the target range? Do you need to go up in dose, go down in dose? Is there hematocrit or hemoglobin going up too fast, in which case you'd want to hold the testosterone replacement therapy and reevaluate. You'd also want to reevaluate if your PSA velocity is increasing too much, obviously if they have a positive DRE for prostate cancer, or if their lower urinary tract symptoms are worsening. So we can replace it, but does it actually benefit patients? Well, here's just a summary table looking at some of the clinical domains and the number of studies that have actually shown supportive evidence for benefits. So with respect to cognition, verbal and working memory, as well as spatial cognition, has been shown to improve in just over half the studies. Less depressive mood symptoms in about 30%. There's been some studies that show increased strength as well as lean muscle mass, decreased fat deposition in just over half the studies. Quality of life tends to be a little bit better. Sexual function is more strongly associated with improvements. And with respect to the lower urinary tract symptoms, I know it's a risk factor for potential contraindication, but the studies out there actually suggest that some of these men are actually having better lower urinary tract symptoms and their flow rates are going up, despite the concern that testosterone can induce proliferation in BPH and worsen it. Also, those people with metabolic syndrome, they find that they actually get better glycemic and control and lipid levels when they're taking testosterone. With respect to bone health, there's some trials that are registered on the government clinical trials website, and some of these results aren't quite back yet. The other thing that's of interest, if you ascribe to evolutionary theory, testosterone is what differentiates men from women and drives some of the behavioral components to induce your genes into the next generation. So if testosterone is differentiating us, then it's obviously changing the way we interact with our environment as well as our behavior. So there has been some experiments that have shown associations with testosterone, either high levels or giving testosterone. Dominant behaviors, aggression, particularly reactive aggression, fear reduction, and they've shown that there's some androgen receptor mediation in the amygdala associated with this. Anxiolysis is another one, and they showed in one trial that injecting people with testosterone actually makes people have a bit of a lack of emotional awareness to others. And then the final one is status-seeking behavior.
You just described 3/4 of the men in this room. Is that because of testosterone?
We're successful in relaying our genes to the next generation.
Lack of emotional awareness.
I hear that one out.
100% of resume.
Yeah. Yeah. So the reason I bring this up is that we don't really see this a lot in the clinical trials that you're reading about with testosterone replacement therapy, and it's a bit of an absence. But it's a realistic question. Can replacement therapy affect our interpersonal relationships, marriages of our patients, or the workplace behavior in these patients that are getting replacement therapy? Let's change gears a little bit to looking at the cardiac risk. So first we have to ask, is cardiac risk physiologically plausible? So some of the detrimental effects of testosterone in the literature that I found was that it can be associated with an increased thromboxane A2 receptor density, leading to platelet aggregation. DHT increases smooth muscle proliferation, and VCAM, which activates monocytes and promotes atherosclerosis. What we touched on earlier, sodium and water retention can put people at risk for increased edema and CHF if those patients are at risk. And testosterone with aromatase converts to estrogen in the periphery, and we know that estrogen has some potential negative cardiac side effects as well. So overall, yes, it is physiologically plausible that this could be the case. What about being beneficial? Is this plausible? Well, we know that from the associations with low testosterone, these patients can have increased levels of coronary artery disease, CHF. These patients typically can have higher levels of stroke, and if there is a stroke, the size can be bigger. We know that with low testosterone levels and high estrogen levels, there can be increased incidence of peripheral vascular disease. And we also know that low testosterone is associated with many risk factors for cardiac disease, metabolic syndrome, central obesity, and diabetes. Looking specifically at testosterone, they've found decreased leukocyte and fibrinogen levels, increased antithrombin 3 levels, improved peripheral tissue oxygenation, improved exercise-induced myocardial ischemia, reduced vascular reactivity, and improved arterial wall stiffness. So the answer here is also yes. So if it's physiologically plausible to be adverse as well as beneficial, where do we stand? It's kind of confusing. So if we look clinically to our advisory agencies, the European agency states that there's no consistent evidence of an increased risk of heart problems in testosterone replacement patients. Okay. What about the FDA? Well, the FDA launched a warning that patients receiving testosterone therapy could be at increased risk of venous blood clots. They also launched a big 209-page document to assess cardiovascular risk associated with testosterone replacement therapy. What they found was that there's multiple studies that commented on this, but there's 4 key studies that's probably worthwhile for us to know if we're going to be prescribing it that our patients could be asking us about. And these are those 4. So we'll go into some of the key points of these 4 studies and some of the limitations from criticisms in the literature. So the first one was a randomized placebo-controlled trial published in New England, and the intervention was giving 100 milligrams of testosterone gel every day for 6 months. Now this study was designed to see if testosterone replacement therapy actually helped their patients mobilize better and regain some strength in the baseline that was actually poor mobile men. So they looked at 209 people. Most of them were over 65 years of age, testosterone between 3.5 and 12, and they had limited mobility. They excluded a lot of comorbidities associated with cardiac risk, as well as BMI, etc., that could contribute to it. The baseline characteristics between the two groups demonstrated that the testosterone group had a higher incidence of hypertension, hyperlipidemia, and statin use just as a baseline. So when they reported all the cardiac adverse events, they reported everything. So if somebody had peripheral edema to their ankles, that was a cardiac-related adverse event. I truncated the list to some of the more significant ones for the testosterone group. So if they actually had an MI, stroke, death, chest pain, etc. And these were higher than the placebo group. When they calculated the odds ratio at the bottom of the screen, 5.8, that was based on everything. So the foot edema, all those kinds of things got lumped together into calculating this odds ratio, which was pretty significant. So some of the criticisms in the literature of this study was that what I was alluding to, the majority of the cardiac events weren't actually big significant events. It was lots of edema, potential hypertension, tachycardia, but there was some adverse events that did happen more so in the testosterone group comparatively. Also, the baseline differences between the two groups weren't equal. The testosterone group did have slightly more risk factor for cardiac disease. And we have to be careful about generalizability of this study, as most of the patients were an average age of 74, and they had low to low normal testosterone levels, but they also had cardiac risk factors. So it's important in identifying that when we're looking at who this applies to. Also, the study wasn't designed to detect cardiac risk. As such, it wasn't powered for detecting this. It was more for looking at mobility associated.
They gave a standard dose. You have men of various sizes, very amounts of fat, and so on. They could show the range of testosterone levels, because really what you're trying to do is get the normal testosterone level and not give the pills to see what happens.
Exactly.
So that would be a design flaw.
Yeah, absolutely. And some of these other studies also have that same design flaw I'll talk about. But you're totally right. The goal is to get them eugonadal and into normal range, not just give them a dose.
They actually gave high doses of testosterone.
Okay. Okay, looking at the next study. This was a meta-analysis of placebo-controlled trials. And here they searched for cardiac-related events. So it included 27 trials of just under 3,000 men with 180 related events. So if you look at the bottom of the screen, which doesn't show up very well, the odds ratio was about 1.54 all studies together. So there was a predilection for increased risk. Here they also commented on another finding was that if you broke the studies into those that were industry-sponsored versus non-industry sponsored, there's a difference in outcome. So those that had industry-funded trials had an odds ratio of 0.9, which was lower than those that were not industry-funded. So it just brings light to consideration, was the design different or was the interpretation of the results different? And we have to be mindful of that. When you look at the actual events between the two groups amongst most of the significant cardiac-related events, the percentages were pretty comparable between the two groups. Some of the limitations that people have criticized this trial was that the population was very heterogeneous. There's multiple different trials asking different questions with different inclusion and exclusion criteria. There's also a lack of monitoring some of the serum testosterone levels during the treatment. Not all the trials also report the cardiac-related events equally. Some only reported the very significant adverse-related events, and some compared all of them. So this was best elucidated with some of them reporting less than 1% adverse events related to the heart, and some of them were upwards of 43%. So there's a really huge range here. And they didn't really comment on the baseline cardiac status if this was comparable amongst all the patients. Looking at the third study, it was a retrospective study looking at patients with testosterone levels less than 300 who were going to undergo angiography for coronary artery disease. The primary outcome was all-cause mortality or hospitalization with an MI or ischemic stroke. They looked at about 8,700 patients. 1,200 of these received testosterone therapy, and they started it on average of about a year and a half following the catheterization. The non-testosterone group as a baseline was different than the testosterone group. They had higher incidence of coronary artery disease, hypertension, hyperlipidemia, CHF, peripheral vascular disease, cerebrovascular disease, and COPD. But they were less obese as a group. So when they did all their calculations, they did adjust for this, the fact that the testosterone receiving group was somewhat healthier. So they used the covariates to adjust for this. What they found was after the adjustment, the cardiac-related events were nearly 20% in the no testosterone group and about 25.7% in the testosterone group. Hazard ratio is about 1.29 for this. However, if you look at the raw data at the bottom of the screen here, this is without the adjustments, and the risk of, or the percentage of death in the testosterone group compared to the no testosterone group was about half. The MI rate was about 1/3 of the no testosterone group, and stroke about half. So the results were actually in reverse before the adjustment for the comorbidities, which is a really big change to the results. So not saying that it shouldn't be taken into consideration. The comorbidities were certainly unequal, but it is just a little bit suspicious that way. So some of the criticisms associated with this trial was that it was retrospective, observational design. These patients that were identified as receiving testosterone were done so by being identified to have a prescription for testosterone, and they weren't necessarily followed for their compliance, their serum testosterone levels, and a lot of these patients were actually under target, less than 300 or less than 400 the target. With respect to generalizability, this is a good focus group for those patients that have cardiac risk, but might not be generalizable beyond this. The other factor was that these were all the numbers were based upon coding, and chart reviews weren't performed for these patients, so they don't actually know what happened with a lot of these patients. And what I was alluding to with prior to adjustment based on comorbidities, the actual incidence of cardiac-related events was about 10% in the testosterone group compared to 21% in the non-testosterone group. So it was about half prior to using the comorbidities to adjust. Final two criticisms were that about 130 of these patients actually had MIs and strokes prior to initiation of testosterone in the non-testosterone group, and these were excluded. So if you included these that were assigned to the non-testosterone group, it would have increased the event rate by about 79%. The author's rebuttal is that all in all, it doesn't change the conclusion of the study, which is fair. And then the final thing was that about 9% of these patients ended up being women. So
You discovered that after the SAT?
after, yeah, it got submitted for publication. And everybody was skeptical, so it was under a lot of scrutiny. So there's
Well, 8.6 on that slide is entirely related to the basic selection going in.
Mhm.
You could make that argument. I mean,
Yeah.
if you have two disparate groups, anyway.
What journal was that published in?
This one I think was JAMA.
This one got huge insights, so you've got
Yeah.
a slide there saying that the backlash on this was
Yeah.
And I'm surprised how many.
But the impact factor is something that's yeah,
Yeah.
Has that target range actually been validated in any way? Do we know that? What's the justification for establishing that target range?
That's a good point. My understanding was that it was just considered. Pardon me. Yeah, within a more normal range. Okay. So yeah, just in summary, this was all the societies that put in an appeal to retract the article, but it did end up going through. The final study that showed the cardiac risk of significance was a cohort study that looked at the commercial claims and encounters database. And here the primary outcome was 90-day MI rate following testosterone prescription. So they compared pre-testosterone prescription to post, and then they also compared those that received a PDE5 inhibitor as a control arm. So the subjects, about 55,000 received testosterone, and about 167,000 received a PDE5 inhibitor. Looking at pre or post to pre-testosterone prescription, the relative risk was about 1.36 overall and tended to increase with age. That being said, in the men less than 65 years of age, the relative risk was actually higher in those that had cardiac disease, whereas the relative risk was lower in those without cardiac disease, although that was not significant as the confidence intervals crossed 1. Comparing testosterone replacement to those that received a prescription to the PDE5 inhibitors, generally there was a trend towards increased relative risk, although this was not significant, nor was this one. However, if you're less than 65, it did suggest that there was an increased relative risk of getting testosterone compared to a PDE5 inhibitor. So some of the limitations here was that we didn't know the indications of why these patients were getting testosterone replacement therapy. They didn't have serological testosterone data at baseline or in response to the replacement therapy, and there was no validation to determine if the patients were actually taking the prescription. We just knew that they had the prescription for TRT. The other thing was that it was a 3-month follow-up period, and we know that when we prescribe testosterone replacement therapy, that the goal is to do it over a long term and not just an acute kind of stint of replacement. Finally, the results didn't comment on any patients that had a mortality in these studies, so we don't know what the etiology was. Now, just so I don't taint everything completely as being cardiac risk adverse, there was also multiple studies that did not show a negative effect. And the most recent meta-analysis that I came across here showed that there wasn't an increased risk looking at testosterone replacement therapy. The main difference between this meta-analysis and the one that was presented with the FDA review was that this study looked at cardiac-related events as major adverse events and then all of the other events independently, and they didn't group them together. Okay, so in conclusion, after looking at all these things, the FDA statement found that there was not any conclusive evidence of increased cardiovascular risk associated with use of testosterone replacement therapy. However, we know that it's not an unreasonable question to ask, and there certainly is some literature out there that still has to make us hyper-vigilant that there could be increased risk, and most likely better designed trials are going to be needed to answer this question. So shifting gears a little bit now, looking at prostate cancer. There's 2 questions I mainly want to address here. One is, does testosterone replacement therapy increase prostate cancer incidence? And 2, is testosterone replacement therapy safe in patients that are deemed cured of prostate cancer? So at the beginning of time here on the left with dinosaurs, we'll do a very simple review of androgens in prostate cancer. So in the 1890s, there was an association drawn between testosterone and prostate cancer. Huggins got the Nobel Prize for demonstrating a castration response in advanced prostate cancer. And based on this research and much other research, we know that prostate cancer is regulated by the androgen receptor activation, and androgen is one of many ligands for the androgen receptor. So if we refresh ourselves a little bit here, we know that testosterone can come into the cell. It gets converted to DHT, which is the ligand to activate the androgen receptor, and this then goes on to produce several transcriptional and translational events that lead to increased PSA, increased cell growth, and increased prostate cancer cell survival. There's also many other ligands that can activate alternative mechanisms to activate the androgen receptor in prostate cancer cells and result in similar downstream effects. Another study later down the line identified that if you were to give people high super physiological doses of testosterone, it eventually reaches a ceiling effect, and at some point there's a limit to giving any more, that it's not going to produce any additional effects in DNA synthesis, prostate cancer cells, etc. So a study to follow up this, they found that in rats, if you had castrated rats and you give them testosterone, the DNA synthesis gets upregulated. But it doesn't happen if you have a rat that has a normal physiologic level of testosterone. So only if they have a very low castrate level. Another follow-up study showed that if you give it within 24 to 48 hours of castrating these rats, there's no change in DNA synthesis. You actually need a response to the castration where you get decreased number of cells and nuclei for the increased testosterone to then have an effect in the DNA synthesis. Another theory that kind of came down the line that's prominent in some of the TRT literature is the saturation theory. And what this theory describes is that as you increase the concentration of testosterone, the potential tumor growth, cell growth increases to a certain point. And at this point, it reaches an asymptote, and it doesn't matter how much more ligand you give, you're not going to have a dependent increase in cell growth. So there's a couple follow-up studies to evaluate the saturation theory. One is a randomized placebo-controlled trial looking at testosterone injection for up to 6 months. They did a prostate biopsy at baseline and a prostate biopsy after 6 months. There's about 44 patients, and one major limitation to this is that it's only 6 months. And if we've learned anything from research in prostate cancer with screening, treatment, etc., you need at least like 13 years or a really long time to find meaningful changes in prostate cancer results. So what they found was that on biopsy at 6 months, there's no changes with histology, prostate cancer incidence, or some of the biomarkers associated with AR gene expression. Looking at the top graphs here, this is the serum levels of testosterone on the left and DHT on the right. After the injection of testosterone, the serum testosterone levels have increased. Same with the DHT levels. But if you look down here in the prostate tissue levels, the testosterone levels and the DHT levels are very comparable. They haven't increased despite giving testosterone replacement therapy. So this brings light to the fact that what you see systemically isn't necessarily what the prostate is seeing. And the prostate has the ability to regulate androgen levels independently of the systemic levels. There's been other studies that looked at 5-alpha reductase and the activity levels in low testosterone. It upregulates to increase DHT from the minimal amount of testosterone it has, so it can continue on its normal day activity and stimulate the AR. There's also other studies that have demonstrated when you castrate people systemically, there's still androgen levels found in the prostate independent if they're castrate systemically. So it's kind of two microenvironments, one in the prostate and systemically it's not necessarily the same thing. Clinically, another study here looking at just under 500 patients, average age of 55, they want to investigate if there is, in fact, a systemic threshold level where you don't have changes before or after. So what they found was that they gave testosterone to these patients based on varying baseline testosterone levels. And those patients that had a baseline level of over 250 did not have any changes in their PSA in response at 6 months. If the testosterone level was less than 250 and they were given testosterone replacement, their PSA did increase by about 0.32 in 6 months. So their conclusion was that there's a saturation level systemically at about 250 or 8.68, where anything below that, the prostate is seeing slightly lower levels of androgen. So when you top it up, it also increases the PSA and presumably proliferation, etc. But if it's already above that, it doesn't make any difference to the prostate in terms of extra superphysiological testosterone with respect to the prostate. However, the saturation theory is nice, but there are several limitations to this. We know that prostate cancer is a very heterogeneous disease. The AR regulates at least 1,500 genes that we're aware of, and it's really unlikely that all of these are ruled by the saturation theory, because there's many signals for proliferation that are activated downstream with various different mechanisms pre and post translationally. So more of the recent work and especially with castrate-resistant prostate cancer, we know that intraprostatic AR activation can be activated independently of androgen through other ligands and other pathways. So if we refresh ourselves again, here's the traditional testosterone DHT AR signaling cascade, and here there's also other ligands that can activate different pathways to get to the same end result. And we don't know what effect testosterone is having on all of these other potential ligands like insulin growth factor 1. We know there's a relationship between testosterone, diabetes, metabolic syndrome, etc. So we don't know the effect to some of these other things that can also affect the prostate, is the take-home point here. So does prostate cancer incidence increase among men getting testosterone replacement therapy? In short, a meta-analysis looking at multiple different studies that have measured this, it does not appear to be so. That being said, we'll just say that because there's no evidence right now, it doesn't mean that it's impossible to have a result. Lots of these studies don't have a long enough duration of follow-up, and there are limitations to definitively answer the question. So what about testosterone replacement therapy in patients treated with prostate cancer? Campbell says men successfully treated for prostate cancer with hypogonadism are potential candidates after a prudent interval if there is no clinical or laboratory evidence of residual cancer. This does make us a little bit nervous, however, because we know that prostate cancer is driven by androgen receptor activation. So there have been some studies that have looked at this, but the level of evidence is pretty low. We only have case series and small numbers, so it's really hard to derive any meaningful conclusions from it. Nonetheless, I'll present a couple of them. This was the biggest retrospective review. It included just over 150 patients, and the mean follow-up was about 2.25 years. Here they had patients, about 103, that had a radical prostatectomy that were hypogonadal, and they compared it to a control arm that had 49 non-hypogonadal men that also received radical prostatectomy. So looking at all the patients together, they found that the PSA velocity was pretty comparable with the replacement group and the reference group, and the number of biochemical recurrences was actually a little bit higher in the reference group than the TRT group. This isn't to suggest that TRT is preventative against biochemical recurrence, just that in this case it doesn't appear to be inferior. This was also the case in high-risk patients where there is a higher rate of biochemical recurrences, but there is no signs of recurrence in the low-risk groups. As I was stating, there are some other small case series commenting on use of TRT in patients that have been treated through other modalities, radiation therapy, surgery, and there hasn't been a lot of reports of biochemical recurrence. So there's just a little smidgen of evidence that maybe this deserves a closer eye and some better design trials to evaluate exactly what's going on. So the data is limited, but if the PSA is undetectable and the patient is having significant symptoms of hypogonadism, then you need to have the discussion with the patient, outweigh the potential benefits of quality of life and some symptom resolution to the potential risks of having treated prostate cancer. And I think that's probably the best conclusion that you can make and take to the clinical practice. Altogether, in conclusion, TRT has been shown to improve mood, libido, sexual functioning, cognitive functioning, body habitus. The data is far from conclusive regarding positive or negative effects on cardiac risk and the interaction with prostate cancer, and it's just about untouched with respect to social behavior in a lot of these clinical trials. That will certainly need more evidence to better answer these questions. However, we would recommend if the patients are truly symptomatic and their levels are low, then maybe these patients would warrant a trial of testosterone replacement therapy. But when you're doing so, have the discussion, fully disclose the uncertainty regarding the potential risks related to cardiac events if they're reading Google and stuff like that, and make the decision kind of together as a team. So just want to thank a few people, and if there's any questions.